A very good evening to all of you. And this is the second series of iConnect Ophthalmic Files on behalf of Orissa Ophthalmic Society. So today we have the topic of diabetic retinopathy untangled. As we all know, diabetic retinopathy is a silent epidemic which cannot be ignored. And it is a leading cause of preventable blindness where 90% of the vision can be uh, prevented from getting lost if there is a timely screening and treatment. So there is an integration not only for prevention, but also for technological innovations that is going on. So we are moving from OCTs to OCT angio to AI-based screenings. There is a paradigm shift also in the treatment part from lasers to anti-VEGFs to pharmacotherapies. And there is a growing role of multidisciplinary care. So hand in hand, the ophthalmologists, the general physicians, and the diabetologists should work together for a holistic approach to a patient care. So with these words, I welcome all the expert panelists, the speakers, and also the audience who are there, and not the list, the office bearers of Orissa Ophthalmic Society. So I just call upon our president, Dr. Sabyasachi sir, if he's there to give his welcome address. Sir, he's there? So since he's not there, so let me introduce our national speakers. Today, Dr. Ajit Babu Maji, he could not join us, but we have two eminent national faculties with us, Dr. Ajay Arora and Dr. Vinod Kumar. So Dr. Ajay Arora will be a bit late to join. So he is the Senior Consultant and Director of VR Services at Vision Plus Eye Center at Noida. And he has a lot of publications and he's a very renowned VR surgeon. So welcome you, sir. We have with us also Professor Vinod Agrawal, who is the professor at VR Services RP Center, New Delhi. So he has a lot of publications, book chapters, a young dynamic. I was with him in one of some meeting for this collaboration for we go on doing for the instruments or equipments. So heard about you, welcome you to this webinar. We have with us eminent speakers, other speakers also. We have other panelists, Dr. Umesh Behra, who is the director and head of the VR services of LV Prasad Eye Institute. Umesh, as we all know, he's a fellow of Arvind Eye Hospital and a silent but a very eminent worker. So welcome you, Dr. Umesh. We have Dr. Sugabrata Parida, who is the head professor and head and VR services at SLN Medical College, Koraput. Welcome you, madam. We have with us Dr. P.K. Sharma, who is associate professor at Vimsar Bulla. Welcome you, sir. So with this, I hand over to our moderators, Dr. Sangamitra Kanunga and Shaswat Behra, to introduce the speakers and start the session.
Yeah. Good evening, everyone. As Dr. Sucheta has already introduced all of the expert panelists, so I'll just go on to the first talk of today's evening by Dr. Bhrutendu. Dr. Bhrutendu has completed his MS in PGI Chandigarh and is working as assistant professor in AIIMS Bhubaneswar. He has multiple publications and many publications to his credit. So the first talk will be recalcitrant diabetic macular edema, its management and case series. Over to you, Dr. Bhrutendu.
Thank you, ma'am. I'll just share my screen.
In the meantime, Dr. Sucheta, can you please ask Dr. Sunil to please help out Dr. Shukla? He is not able to join.
I think the screen is visible to all.
Yes, it's visible.
Okay.
Please go ahead.
Now, before we talk about the management of refractory DME. Let us first discuss a case. This is a 73-year-old female. She has been diabetic since 23 years. Also hypertensive, but hypertensive and diabetes are well controlled, and there is no renal failure, no CKD, or there is no coronary artery disease. Now, when the patient first presented in January 2021, okay, now, here we can see the best corrected visual acuity in the left eye was 636. Okay. Now, also the right eye had similar presentations, but for the this presentation purpose, we'll discuss only the left eye. So the visual acuity was 6 by 36, and the fundus photo we can see that there are a few hard exudates here, and it was a moderate NPDF. And on the OCT, we can see the cystoid macular edema with a lot of hard exudates here. Okay, and the visual acuity was 6 by 36. So the patient was advised to receive injection of bevacizumab. Then the patient received monthly injection of intravitreal bevacizumab, and she received a total 6 doses of bevacizumab between January to September, in a period of around 8 months. Okay. Now, with injections, the cystoid macular edema, it definitely decreased, but it was not satisfactory. There was no complete resolution of the fluid. Also, the visual acuity at the end of 8 months, and after 6 injections of bevacizumab, the visual acuity did not improve. It remained at 6 by 36. So in this visit also we can see the hard exudates are still present there, and we have a lot of intraretinal fluid cystic spaces, and these are all the hard exudates are there. Okay, so now after that, decided to go for injection ranibizumab. Okay, now with injection ranibizumab, the patient received 5 injections with a period of around 7 months. Now, after 7 months also, we can see the visual acuity remained at 636. There was not much of improvement. The fluid from the previous visit has decreased definitely, but still these interretinal cystic spaces, they persisted. There are multiple hard exudates. Also, there is epiretinal membrane here, and there is spongy edema all throughout the retina. Also, in the fundus photo, we can see there are a few hard exudates here. There is epiretinal membrane, and the issues is there, and there is no significant improvement in the visual acuity. Now, because the patient has received a lot of intravitreal anti-VEGFs, multiple bevacizumab, and multiple ranibizumab, so next our plan was to give injection Ozurdex. Now, with injection Ozurdex also, she received multiple injections with a gap of 3 to 4 months between each injection. And here we can see that after around, this is in the June, this is after around 6 months, the fluid has decreased. Okay, the epiretinal membrane is there. There are multiple hard exudates. Here we can see that the hard exudates have decreased than before, and the visual acuity has improved to 6 by 24. There is still not much improvement in the visual acuity. Now, because the fluid has not resolved completely, so the patient continued to receive intravitreal Ozurdex. Okay, every like 4 months or 5 months, we have to give intravitreal Ozurdex, so that the fluid, the dryness of the macula can be maintained up to some level. Now, here is also in June 2025, we can see that the fluid has decreased significantly, but still there are multiple cystic spaces. These are the multiple hard exudates. Also, there is a epiretinal membrane here, and the visual acuity was 6 by 24. Okay, it's never became 6.9 or 6.6 in this patient. Here also you can see there are multiple hard exudates. These are present. Also, while the patient is receiving those treatments with intravitreal anti-VEGF injections or steroid injections, the patient's blood sugar level was fairly good. It was well controlled. Hypertension was also controlled, and other systemic profile was good. Okay. In the latest visit, that was in the July of sorry, this was 7/3. Okay, this was the 7th of March 2026. It's not the otherwise. Okay, there is also, you can see the epiretinal membrane there. Again, the fluid has recurred. And from the previous visit, the fluid has increased. There is multiple hard exudates. The visual acuity remains 6/24. We can see a lot of hemorrhages and lot of hard exudates here. Now, we have again planned to inject the patient with another Azudex injections. Now, such cases actually we call them as a refractory diabetic macular edema. Now, by definition, it's a persistent retinal swelling and visual impairment that does not adequately respond to standard anti-VEGF therapy. And the typical definition is when the patient has a central macular thickness of more than 300 micron, or there is less than 10 to 20% reduction in the CMT from the baseline after 3 to 6 consecutive monthly intravitreal injections. Okay. Now, among all the landmark clinical trials about the anti-VEGF and our diabetic macular edema, it is seen that almost 40% of the patients that were included in those landmark clinical trials, they become a case of refractory diabetic macular edema. Now, what options we have of these patients? Now, when the patient is not responding to one particular anti-VEGF, so most of the times it can be a case of tachyphylaxis, that the patient has developed resistance to that particular anti-VEGF agent, be it bevacizumab or ranibizumab. So in that case, switching to an alternate anti-VEGF agent is required. If the patient is receiving bevacizumab, we shift to ranibizumab or vice versa, or even to aflibercept. Okay. So the other options are using intravitreal steroids. Now it's well known that in the pathogenesis of diabetic macular edema, anti-VEGF, the VEGFs are the main culprit, but also the inflammatory mediators like interleukin 6 and interleukin 1, they are also contributing to the development of macular edema. So in these cases, using intravitreal steroids like Azudex, or also those who cannot afford, we can use intravitreal triamcinolone acetonide. They can help in resolution of the macular fluid. Also, in some cases, we can use focal laser. Let us not forget what was the gold standard of managing diabetic macular edema few years back before the advent of anti-VEGF agents. Also, some cases doing a focal laser adds to the effect of anti-VEGF agents, and by their contributory effect, we can get a faster resolution of the faster decrease in the central macular thickness. Okay. Now, the previous studies have shown that switching to intravitreal aflibercept from either intravitreal ranibizumab or bevacizumab is associated with moderate to significant improvement in the central subfield thickness. It may be an appropriate choice for patients with refractory DME. As I have already said, some patients develop tachyphylaxis. So, by changing to another anti-VEGF, the effects may be better. Now, usually it is seen that there is improvement in the retinal thickness in edema, typically after receiving 3 injections of the post switch. I mean, if the patient is receiving intravitreal Avastin bevacizumab, we switch to ranibizumab, and after 3 injection of ranibizumab, there is significant improvement in the retinal thickness. Also, switching to intravitreal aflibercept or switching to intravitreal ranibizumab from bevacizumab, it has also demonstrated improvement in the central retinal thickness 3 to 6 months post switch. Okay, so I mean, if we get a patient of refractory diabetic macular edema, even if we switch, it takes almost 3 to 6 injections to control the central macular thickness. Okay. So Now the various options that we have apart from changing the anti-VEGF agent, we have Ozudex. Those who cannot afford, we have intravitreal triamcinolone acetonide, also focal laser. So other important points is to rule out tractional component. Like in our patient, the patient also has an epiretinal membrane. Now that is thick. Now that epiretinal membrane also must be contributing to some kind of increase in the central macular thickness, and also parts from a vitrectomy. Many like traditionally what we learn that when the vitreous is there, all those VEGFs molecules and the inflammatory molecules, they're trapped between the posterior hyaloid and the retina. Okay. Now those refractory cases that is not responding to any of the anti-VEGFs or steroids, doing a vitrectomy, we remove all the vitreous, so all the trapped inflammatory mediators and VEGF molecules, so they get diluted in the whole vitreous cavity, and also during the surgery they are all removed out. Now that leads to faster resolution of central macular thickness. Also those patients where there is a tractional component, like this patient is in epiretinal membrane, or in some cases there is some vitreous traction that is contributing to the central macular thickness. So in all these cases, doing a vitrectomy will also help in faster resolution of the macular thickness. So, saying all that, the most important thing is the systemic control. Unless a patient has adequate control of diabetes, then whatever treatment we give, anti-VEGF, steroids, or anything, that is not going to work. Now we have to ensure that the patient has age appropriate level of HbA1c. Like having HbA1c of 7.5 at the age of 60 to 70 may be fine, but that may not be fine if someone is within the age of 40 to 50. So there is appropriate age appropriate level of HbA1c, and that should be adequately controlled in all patients of diabetes mellitus. Also, there should be adequate control of CKD. In CKD, there is loss of protein, and hypoproteinemia can lead to increase in macular thickness. There should be adequate control of hypertension. There should be optimal level of hemoglobin, serum albumin, also serum cholesterol levels should be adequately controlled. Now, provided that there is a good amount of systemic control, so with that we can whatever local treatment we are giving for the DME, that will have a better effect. Thank you.
Thank you, Dr. Bhutendu. It was a nice compilation of the case and a good summary of recalcitrant macular edema. So I would like to call upon Dr. Vinod.
Dr.
Sir,
Vinod, Dr. Vinod has just gone for 5 minutes, and he just messaged me that he will be joining
okay,
back me in 5 minutes. So we can
okay,
discuss with
okay.
other.
I think Dr. Ajay has also not joined.
Okay.
Can Dr. Umesh take up the discussion? Dr. Umesh is there?
Yes, yes.
Yeah, sure. Bhutendu, a very nice
Yeah,
case.
so
Yeah,
thank
so
you.
in this case, Dr. Umesh, as there is a ERM there, do you think as he has given a lot of multiple injections of all categories, do you think you would go in for a OCT to find out if there is a macular ischemia, or a FA to find out the peripheral ischemic changes, whether you should go in for a peripheral PRP or a micropulse laser, or would go in for a vitrectomy in this case? Your take, Dr. Umesh.
Yeah, first of all, it's a very good case, Bhutendu, and good case scenario to initiate a discussion. After injection of bevacizumab, 6 injections, I think there was already a membrane on the macula. I think that was the point when the surgeon could have decided whether to go for a surgical maneuver. But if that did not permit, then laser photocoagulation, great laser photocoagulation was another option which I would have definitely tried. Although we saw that anti-VEGF and dexamethasone didn't have much of effect over 3 or 4 years, possibly the patient's macula was ischemic, means we can presume it's always wise to get the fluoresceint angiography done to note the extent of macular ischemia or to redesign the treatment. The patient also had a chronic kidney disease. That is one of the most frustrating part of macular edema treatment if you have multi-systemic disease. So these have already contributed to the cocktail, and possibly that is why the macular edema did not respond to our satisfaction. Given the question of whether we should be going in for peripheral photocoagulation, if this patient has neovascular complications, I may consider. Or if the patient has very extensive capillary dropouts, one may consider. But the evidence is not strong enough to suggest that peripheral photocoagulation will reduce the macular edema. But these cases, vitrectomy could be one of the options, because with vitrectomy, you increase the oxygenation of the macula, and the turnover of the cytokines are also faster. So this is my take, how I could have treated it.
Thank you, sir. I think Shukla sir has raised his hand. Said, do you want to speak something?
No, I didn't raise my hand, but yeah, I can speak.
Yeah. So before you speak, can I just put a word like a very well case by Dr. Brutendu. Like in this case, the patient was started with bevacizumab, then with ranibizumab. So my question is that if it is a resource scarce condition and if it is a resource rich condition in which the patient does not have an issue of money, which will be your first choice of anti-VEGF in such type of patients?
So you are asking me or asking Ritendu?
I'm asking you, sir, Shukla sir.
Okay, so first of all, my default is Eylea or in most of the cases of diabetic macular edema. It has got the most bang for buck if the patient doesn't have a problem. Now you have got a biosimilar, so I think I would like to try that. So I have a particular problem with Avastin. Avastin isn't whole antibody, so it is more likely to cause an ERM formation than any other drugs actually. So that is might be one reason why there was an ERM which was causing the macular edema to remain persistent. Now, as to Sangmitra's suggestion about vitrectomy, the thing is it depends on whether the ERM is flat or it is pulling at the retina or not. If it's a globally attached ERM, it is just a consequence of a chronic macular edema, and probably removing the ERM will not help, as might be in this case. I have a case, at least a few cases, one case on record, where a very senior surgeon in South had advised vitrectomy for a similar case. I just settled it with Ozurdex actually. So Ozurdex, as he suggested, is a good idea, and it did not work. We also have to reconcile ourselves to the fact that when the randomized trials could not settle 40% of the diabetic macular edemas, we have to learn to say that to the patient that we failed. That's it. It's as simple as that. So it's not that you have to dry up the macula at any cost. The other things have already been considered very well by Umesh and Sangamitra and even Ritendu himself. So it's a beautiful case, and it affects all of us actually. So these are some of my issues. Thank you.
So my question will be, if we are starting with Eylea, like what you prefer, how commonly have you seen recurrences or a poor responder with Eylea? Because now Eylea is extreme. If patient is paying, his expectations are quite high, and we are giving him the best fluid reduction injection. So
And
how
after
commonly have you
Eylea, which anti-VEGF to switch
True,
over?
ma'am. That was my next
If we are
question.
giving Eylea at the first go.
Yeah. So first of all, the other drug is faricimab.
True.
So faricimab does not take has as dramatic or wow effect as Eylea, but it does kick in after a few injections. Of course, we are completely ruling out the financial part. Actually, we are talking only about science. So, and if faricimab doesn't work, then I'd look at Ozurdex. If that doesn't work, then I'll just say sorry to the patient, right? So I will not go in injecting. But as Bhatendu pointed out very importantly, you have to say when to call refractory. So he said after 2 to 5 injections. So that you have to decide after how many injections you are going to call it refractory. 5 consecutive injections may not have been given monthly. So if they have been given several months apart, then they don't count as consecutive injections. So you have to give consecutive injections to call it refractory, and you have to say sorry to the patient at some time. There's no shame in that. And for those who are cost sensitive, there are biosimilars available. I don't know what's the name, Umesh. There is a biosimilar now available for Eylea, so we can try that.
Zydus, I think.
Yeah, Zydus drug. Yeah, exactly. I haven't tried it.
I have a question to Dr.
Yeah,
Muralidhar,
Zydus.
sir. Can we, Muralidhar, sir? Sir, question for you. Have you ever done PRP, not focal laser, in a case of poorly responding diabetic macular edema? Patient is not affording, like you have done focal also, it's not responding, and you are not seeing any NVEs.
Actually, not focal. We should do subthermal grid in this because central macular thickness is raised here. It is a spongy edema, not focally. We should not do focal laser, rather a subthermal grid laser.
So micropulse laser was there, but
Yes.
actually the patient is
If
already having a
micropulse not
ARM.
there, we can give a subthermal laser also.
The main
Just
issue is there is
reducing
already.
the dose. Yeah. But how will
But
you do focal in a diffuse edema where central macular thickness is raised and central macula is also involved?
and the
Diffusely.
patient has the ERM actually. So
Exactly.
in a case of
And
ERM,
ERM was not there on the first visit. What he showed in 2021, there was no ERM. When he gave bevacizumab, and that also when we have biosimilars also, I think I don't repeat so many injections, and switching from bevacizumab to ranibizumab also, I don't find any more positive effect of it. If we are failing with bevacizumab, then we should switch to some other product. And in my view, if there is a ERM, and surprisingly, from 2021 to 2026, for 5 years, patient has not responded at all. Somewhere in some visits, there just the large cyst has decreased its size. Otherwise, the thickness is almost same. And vision is also maintaining from 636 624 from first visit to last visit.
I have a
One
question.
thing I want to say,
Yeah. Sarvaj, please.
one thing, uh, just if there is recalcitrant DME is there without ERM, one should actually review the anti-diabetic drug, because most of these patients, they are receiving actually 3 drugs. One of them is pioglitazone. So in our hospital, so I used to see these patients having recalcitrant DME actually. On consequent 3 to 4 injection after, when I found these things, I send a request letter to the treating physician, please omit pioglitazone, because this pioglitazone is one of the cause of recalcitrant DME. So I want to give emphasis on that point.
Thank you, sir. So I have a question for Vinod, sir. Vinod, sir, presently there are multiple biomarkers. At least literature is showing 10 to 15 different type of biomarkers. In your experience and in your practice, if in a descending order, if we put these biomarkers will be a poor responders or there is a risk of recurrences, how would you put them? Which is the biomarker that is very much likely to have a recurrence or a poor response? Sir, you're muted. Please unmute yourself. Yeah.
I think that's a very difficult question to answer, to put everything in a descending order. But yes, I think there are few markers. The most difficult to treat is, I think, chronicity. So when you have those cystoid kind of edema where the tissue septae are broken, and when you see there are large bullae, those are the cases, especially if they are, hyperreflective dots in between them, in the cyst. That is something which is the most difficult I find to treat. Chronic CME with broken septae, and especially with hyperreflective dots, which may be just HRFs or hard exudates. Either way, they are the most difficult to treat. You kind of you can keep on treating with that anti-VEGF, they don't go away. You give steroids even with long acting implants, they temporarily go but again come back. So that is something which gives you a clue that it's very bad prognosis. I think apart from that, hyperreflective dots, these are the things which are very bad. But in general, if you talk in terms of prognosis, then the loss of integrity of layers, whether inner or outer, inner we call them drill and outer is the integrity of EZ and ELM. If those are gone, then it usually does not lead to a very good outcome. But I think chronicity is, for me, the signs of chronicity are very bad. The reason being, I see many new naive cases. They come to us, and irrespective of treatment, whatever you give, whichever anti-VEGF you give, they tend to respond well. When it comes to chronic cases, who've been treated before, those are really difficult ones.
Thank you, sir.
So,
Michelle,
Dr.
should
can
we,
I,
should we, yeah,
can I,
yeah,
I'm sorry, I got very
yeah.
delayed.
please.
Can
Good
I just
evening,
add
good
a
evening,
few
sir.
points? Yeah, I got caught up in a surgery which extended beyond my this thing, started very late. So I think what Vinod just said about chronicity, I know the intraretinal fluid is classified into small, medium, and large. So whenever it is more than 200 microns, which basically what Vinod said, has got septae which are broken in between. So that indicates chronicity. Second, I think, is when you have hyperreflective foci which are subfoveal in nature, which basically indicates lot of microglial cells which are there in the subfoveal area, or a lipid exudation in the subfoveal area, where again you don't expect visual acuity to recover much. So what we have found is that in these cases which are chronic and they are not responding, so it's response to anti-VEGF also, we have to see how many anti-VEGFs you give before you say that it is not responding to an anti-VEGF. So normally what we believe is about 3 anti-VEGF. Some people say 6 anti-VEGF, as Neil Bressler says that about 6 anti-VEGFs. But in our country, we can't give so many anti-VEGF because of economic issues. So in my practice, we have been doing suprachoroidal triamcinolone injections, and those are giving us very good results as such. So I think many cases who are recalcitrant to anti-VEGFs, in these cases, we are using suprachoroidal triamcinolone without an increase of intraocular pressure. You can certainly use DEX implants in these cases, and they definitely work pretty well in these situations. We have also been doing micropulse laser to reduce the number of injections, and to some extent, we have been successful. But then anti-VEGF is the go-to molecule for the initial injections. If you have a pseudophakic eye with hyperreflective foci, then of course we can go directly with steroids.
Thank you, sir.
Thank you, sir.
So our
So,
next speaker will be Dr. Dhananjay Shukla, sir. Dr. Shukla is an extremely well-known figure in the field of retina. He is currently the consultant at Ratan Jyoti Nethralaya at Gwalior. Sir has multiple publications along with chapters in the Ryan's Retina that we all read. So it's my honor to introduce sir. Sir, can you please share your screen for your presentation?
Yeah, I'll try to share it.
Along with that, sir is quite a great fitness guru. So we should all learn from him how to keep our health online.
He has done the Boston Marathon.
I know he
Yeah,
is,
yeah, yeah. That's
yeah.
awesome.
Lot of marathons to his credit.
He is our idol actually for all these. He keeps telling
Thank
me
you, friends. Thank you. Just tell me, I'm really lousy with this thing. How? Where is the share screen?
You will have in the bottom, sir, you will have
Bottom
a raise hand, and to the right, you will have a shares.
share
Oh,
screen.
yeah. I'm doing it after a long time, so I think I've got it now. So you can see my screen, right?
Yeah, it has started
It,
to. Yeah.
yeah.
You can make it full screen, sir.
Yeah, I'm making it full screen. So thank you, Sangamitra. If you remember, you once showed me a case actually. In fact, you and Naresh came together with that case, and that was a case which made me make this presentation long time back actually. That retinopathy in a diabetic eye is not always diabetic retinopathy, and we should remember that actually. So let me share my experience with that in a series of cases, which I'll go stepwise according to complexity. So Levenwall was a 42-year-old man with type 2 diabetes for 6 years. He had bilateral visual loss for last 1 month, and his vision was, he was practically blind. He was 1/16 both eyes. There was no headache or vomiting. I'll tell you why I'm giving these symptoms. He was referred a case of severe NPDR plus diabetic macular edema with papilledema. But they had already done a CT scan and there was no evidence of any space occupying lesion. So this was the picture which the patient presented with. And I remember his vision was 1/60. And look at the kind of hemorrhages, look at the disc, look at the peripapillary area. And now this patient, when we did a systemic evaluation, we found that the patient had an extremely high blood pressure actually. And his diabetes was also slightly out of control, but not bad. He had deranged cholesterol, of course. We also did a workup for cardiac carotid and collagen vascular disease just to be sure, but it was negative. And his abdominal ultrasound confirmed that he had a renal hypertension, which was of a malignant nature. So we call hypertension malignant when the blood pressure is 180/110, along with bilateral disc edema or even grade 3 hypertension. But if you look at these pictures, it is actually not disc edema. If you look at the vessels at the edges of the disc is not elevated actually. It is just hyperemic and there's peripapillary edema. So that is the cue in this case. This patient, we gave intravitreal steroid in the left eye, and after a year, he responded very well to just BP control in both eyes. But he became better in the eye in which intravitreal steroid was given. I'm not recommending that as yet, but I'm just saying that these patients can improve a lot, but they lose some vision because of ischemic optic neuropathy, which underlies this disc edema. So this is the arrows show the residual signs of malignant hypertension, which should be able to recognize. This is not, and the black arrows show what are Elschnig infarcts. So these are telltale pictures of malignant hypertension, because the patient, when he comes later with 130/80 BP, you may not recognize it as malignant hypertension. You may call it a resolved choroiditis, but this is just a resolved malignant hypertension. It is extremely common with diabetes. In fact, a client said that we should not ask whether the diabetic has hypertension. We should see if a diabetic does not have hypertension. And even in the case which looks like a bilateral papilledema with no other signs of retinopathy, either diabetic or hypertensive, we should check BP once, because you can have this disc edema alone in some of these cases, or apparent disc edema with the malignant hypertension. The other clues being, if you look at the OCT, you find that the macular edema or macular star is actually more of a macular detachment. We actually showed them in a series of cases where macular detachment was omnipresent in every single case. And actually, disc edema was not bilateral in all cases. That has been suggested in malignant hypertension. The other cues, the retinal lesions are centered around the optic nerve head, as you see in the picture here actually. So the lesions are not in the macula as in diabetic retinopathy, but centered around the optic nerve head. And the BP control itself improves diabetic retinopathy to some extent. Level 2 was at a 57-year-old diabetic for 10 years. His best credit visual acuity this time was 6/9 both eyes. So nothing to worry. But he was diagnosed as severe NPDR, both eyes, with central diabetic macular edema in the left eye. If you look at the OCT, this looks like a logical diagnosis. The patient was advised anti-VEGF injection for the left eye. But when we look at the fundus, it shows a different story. It looks like more like a CRVO, and that too with pale-centered hemorrhages. So this patient was, am I audible to you? Am I audible to everyone?
Yes, yes, sir.
Yeah,
Yes,
yes,
sir. Yes, sir.
Yeah, because my connection, it shows is unstable. So he was found to be severely anemic. And when we did a leukocyte count, it was extremely high. So the normal count is up to 11,000. It was 1,78,000. Platelet count was on the upper edge of normal. We sent the patient to an oncohematologist. It was diagnosed as a chronic myeloid leukemia. The patient, I don't have a follow-up picture, but he became absolutely normal with a normal looking fundus in both eyes after the treatment for CML. So when you have central retinal vein occlusion and diabetic, diabetes itself is a risk factor. but it does not cause typically a bilateral CRVO. So when we have a bilateral CRVO, we should look for blood dyscrasias, which can be simple anemia, or it can be, even a blood cancer, as in this case. The main differential diagnosis is the anterior extent of the blood hemorrhages. So in a severe NPDR, the hemorrhages do not extend to the periphery, which they do in CRVO, and you do not see other features of diabetic retinopathy like the soft and hard exudates in these kind of CRVOs. Also in this particular picture, you have to look at the nature of the hemorrhages, which was pale-centered. And these cases, when you have such cases, simply you have to check hemoglobin, peripheral smear, and blood counts, and that's enough to clinch a very important diagnosis. Level 3. This was a patient, a 54-year-old male patient with diabetes and hypertension. He had again a 6/6 in both eyes. He had what looked like hard exudates in the left eye if you look at the arrow, but if you look carefully, they look a little more dull as compared to regular hard exudates. Now, when we did the OCT of this patient, he had a pachychoroid in both eyes, and he also pachy vessels in both eyes, which was definitely abnormal. And also you can see an RP atrophy in this area, which was confirmed on autofluorescence. So this patient, just for reference, we asked him a history of laser treatment. There was no laser treatment. So this was a patient of chronic CSCR, which was diagnosed as a case of diabetic retinopathy because of those lipids, subretinal precipitates, which were diagnosed as hard exudates, but they are much more dull as compared to hard exudates. Level 4. This patient is a 68-year-old patient, much older, diabetes type 2. Vision was 6/6 in the right eye. I'm showing a small picture of the right eye, and 6/24 in the left eye. Just for reference, I'm showing you the pictures with which the patient was referred to me, and also my own mistake in this patient. It was diagnosed elsewhere as a case of moderate NPDR with DME in both eyes, and he was advised laser for DME in both eyes. So if you can see that there looks like a clinically significant macular edema, but when you look at the OCT, there is no DME. So I was clear no laser treatment is required, but I did not look carefully at the spam, which was seen even in this poor quality OCTs. And therefore, I had this patient coming to me 3 days later with the PL vision. And now he had a clear-cut central retinal artery occlusion. And this can be diagnosed with OCT alone, by the way, with the complete opacification of the inner retina. So it beautifully shows you the extent of the retina, which is supplied by central retinal artery. The outer retina is not supplied, so it is completely normal. You can see the outer retinal bands are also normal, but the retina has lost all its function because of loss of this. Fluorescein angiography is not required actually, first of all, and secondly, it confuses people more than it enlightens them. For example, we do not know that the commonest diagnostic feature of CRA is increased AB transit time. And as you can see this picture, which you see in this patient in mind as a FFA of CRO, then you will be able to diagnose CRO only in 2% of the cases, because most of them only have an increased AV transit time. Of course, it is not classic of CRO. It can occur as ischemic CRVO also and ocular ischemic syndrome. But when CRO kind of picture is there, this is what should be looked for. Diabetes is indeed a risk factor. In fact, cardiologist has told that a diabetic patient is already a cardiac patient. So when there is a disproportionate visual loss, it should always alert us. Like in this case, there was no macular edema, but a lot of loss of vision. OCT is enough to diagnose, and this needs a cardiological evaluation and subsequent tests. Level 5. This is a 50-year-old patient. He had type 2 diabetes and hypertension. The vision was 6/6 in the right eye, which I am not showing here, but was 6/18 in the left eye with apparently mild NPDR and CSME in the left eye. Now, what is wrong with the CSME? We'll see when we do fluorescein angiography and OCT. Fluorescein angiography does show some leak, but this leak is not typical of diabetic macular edema. In fact, where you see the microaneurysms in the green arrow, you do not see the leak. You are seeing the leak just temporal to the fovea. And the clinching picture is here. In the OCT, instead of edema or increased thickening, you are seeing atrophy. So this is a patient of MACTEL2, and the irony is it is commonly associated with diabetes or hypertension. So always do an OCT along with fluorescein angiography, and this shows you whether to treat or not to treat. Because if you do a laser treatment, you can actually precipitate the formation of a subretinal neovascular membrane. It is a neurodegenerative disease commonly present in diabetes and hypertensives. There is no treatment unless there is unless there is subretinal neovascular membrane present, and laser treatment only aggravates the conditions. So please do not treat it and do an OCT. The final level, this is a diabetic hypertensive patient of 40 years of age. Vision was 612 in the right eye and 66 in the left. Now look at the right eye, which I'm showing to you. He already has an NVD. So what are we looking for? There's already a high risk PDR because he has got massive NVD and a DME. And left eye surprisingly had a mild NPDR with no DME, so it was an asymmetric diabetic retinopathy. But it was explained by ischemic optic neuropathy in the left eye. OCT was a shocker. So, and FFA was a bigger shocker. So I'm going to share both. So when you do an OCT of such large and massive NVDs, you expect a fluorid leak into the vitreous, like a cotton ball hyperfluorescence, as the textbook calls it. Look at these vessels. They are just seen as ghost vessels, as if they are not leaking at all, actually. And if you look at the OCT of the same patient, you are seeing the macular edema focused more on the papillomacular bundle than into the macula. So this patient, and there is some traction on the disc. The left eye, of course, shows an ischemic optic neuropathy, which explains why there is an ischemic diabetic retinopathy and the two eyes. But I was not satisfied about the need for anti-VEGF in this eye, so I withheld the injection. This was in Arvind, actually. When the patient came second time, his vision had dropped to 636. So I thought that I have actually made a mistake. This patient has bled, but the patient had bled for a different reason altogether. That it was not the new vessel which had bled. It was the contraction of the fibrous tissue on the disc. And actually the macular edema has decreased. So if we compare this macula with the previous picture, see that there was a macular detachment and macular edema, both have decreased. So in spite of decrease in macular edema, there is a worsening of vision from 612 to 636. So I thought that this could be a case of something else. So I read about it and I found that this was what is known as vitreopapillary traction or tractional diabetic papillopathy. So I explained to the educated patient that you actually need a vitrectomy. I'm seeing this patient for the first time, this kind of patient for the first time, but I know what to do in vitrectomy and I just have to remove the vitreous traction on the disc. The patient fortunately agreed, and this went on very well, and we could improve the patient to 6 vision with the release and traction in the disc. And by the way, I did not do any PRP in this patient. So vitreopapillary traction in diabetic retinopathy can occur because of distortion of the retina due to vitreous. It occurs to some extent in every PDR, but it can occur even in NPDR. So you should suspect it when the vision doesn't correlate with the maculopathy, and be suspicious of an NVD when it is asymmetric. Fluorescein angiography and OCT can clarify the issue in most cases, and longitudinal follow-up confirmed the diagnosis in this patient. So the take-home message from the series is, everything in a diabetic eye is not necessarily diabetic retinopathy. Fluorescein angiography does not always indicate treatable diabetic macular edema, and OCT confirmation is necessary, as we saw in the Mactel case. Asymmetric diabetic retinopathy should be investigated carefully. Medical treatment may be enough for diabetic macular edema, especially when associated with uncontrolled hypertension. It is unnecessary and damaging to treat a case of mactal leakage and diabetic retinopathy. And finally, as Arthur Conan Doyle, through his character Sherlock Holmes, told us, eyes only see what the mind knows. Thank you very much.
Thank you, sir. It was an excellent presentation.
Thank you.
Just one question, if you can answer. In a diabetic patient with retinal changes, what are the key red flags that you should make us think one should think beyond diabetic retinopathy?
Come again, I did not get your point. In a diabetic patient with retinal changes, what makes you think that it is not diabetic
What are the
retinopathy?
key red flags that one should see make us think that beyond diabetic retinopathy?
So I have shown you all the red flags, actually. The nature of hemorrhages, for example. See, anything which is, first of all, in a diabetic patient with retinopathy, presume it is diabetic retinopathy. There's no harm in that. 90% you will be right. But we are talking about the other 10%, right? So how we find that, there are even more examples for this, but basically you are seeing that the vision is going down, but there's no macular edema. So then don't
Correct,
blindly
yeah.
go for treating any hard exudates or macular edema. If there is no central macular edema, then the cause for visual loss is something else. Maybe we are not able to find it, but at least don't treat it. So let us just be curious when the symptoms do not correlate with the clinical findings. I mean, that is maybe in short the answer which sums up all the findings.
Okay.
I have one query.
Sir, just can I
Sangam, I have
comment?
one query.
Doctor, just 1 minute.
Yeah,
So,
yeah, okay.
Dr. Sukla sir, nice to meet you after a long time. It was
Nice to
a
meet
very
you too.
pleasant. Yeah. So actually, we have one case where the patient is a diabetic hypertensive, just presented with us like this bilateral disc edema, we can call it, so much of hemorrhages around. And then we did a BP in the OPD and we found out there was a high blood pressure. So thinking that yes, we send it to a general physician to control the BP. Patient is again coming back to us with again diminution of vision. So we thought, probing into the matter, then we asked, he had some history of headache and all. So we thought, why not to go in to do a MRI in these cases. So we asked for a MRI orbit brain, and we asked also for MRV in this case. So what came out to be in the imaging was this patient was having actually dural sinus thrombosis, and sent to the neurologist, had other tests done. Patient also was suffering from polycythemia. So sometimes even a diabetic patient and hypertensive, we just don't think to think of doing certain neuroimaging, because we always know, yes, bilateral edema can it be, but bilateral is something very difficult to say. It will be a presentation of diabetic retinopathy, but yes, hypertensive retinopathy malignant, what you were talking about, we thought initially as that, but this is how we patient followed. So just to add it, yes, there can be
Beautiful
some
points.
uncommon presentation of.
Very beautiful points. I just want clarification. I showed you the disc again actually. And when the patient will have malignant hypertension, first of all, what was the BP in your patient? What was the blood pressure in your patient with this dural thrombosis? What was the blood pressure? You said it was high.
It was
How high?
Yeah, 220. Yeah, 220 it was.
So it was in the malignant range. So there can be one more thing. What is the female patient can be pseudotumor cerebri. So yes, I agree. One thing is in diabetic disc edema or hypertensive disc edema, the disc is not that much elevated actually. So that's what I tried to show you actually.
Yeah, that is one point.
So it is not elevated actually. If the edema part, it's not jumping at you. It is remaining. If you look at the vessels, they were actually coursing over without change in their course. Actually, I showed you that picture again. If you were you looked at it, but you made a very good point that a neuroimaging is anyways must. Actually, it's a medical legal requirement actually. But the thing is, you should not do it yourself. You should just send him to a neurophysician and let him decide what investigations are required.
Yeah,
That's what I would
because
do definitely. But very
so
good
it's an
points. I fully
institute,
agree.
so we usually
Yes,
have
yes.
the physicians.
I agree with this thing that neuroimaging is required still. Thank you.
One question from my side to Dr. Sukla.
Yes,
Dr. Saswat, just a minute.
Please, ma'am. You're
Yeah.
only.
It's a very good series of cases, Dr. Sukla. Thank you so
Thank you.
much. I just have one query. In your first case, you showed bilateral, that means grade 4 hypertensive retinopathy to a malignant hypertension. In that case, in both the eyes, I think you injected the Ozurdex implant, right?
No.
And you showed no.
Only in the left eye injected.
Only in the left eye. So that is my query only. When you decide to, like in every cases, we don't do, we just observe and control the hypertension. And usually we see the resolution of the edema and all.
Absolutely.
So when you decide actually to inject Ozurdex in such a case?
That's an excellent question. The first thing is the point of showing that case was not to show the treatment at all, but to show that this case is possible.
Yes.
So you do the right thing. This is the 90% of the thing what you are doing.
Okay.
Why I injected? Because this patient was a young patient. He was 1/16 both eyes. So he had actually legally blind on both eyes. So
Yes.
I did not have any idea what IVT will do. There was a time, I think Vinod and Ajay will remember, we used to inject IVT in everything. Anything which you can't figure out to inject IVT. So I'll accept that. In those days, I injected IVT for this reason only. but it helped a lot. And the patient actually asked me after a year, why did you not inject in both the eyes? But I cannot
Okay.
claim to know why it helped, but I have got a series of cases now. Maybe I'll publish it in the future. But yes, the main thing is think of BP. That's all. I'm saying something
Yes.
saying something very simple. And as has been pointed out, refer to a neuroimaging if there's
Yeah.
a disc edema, if the disc is significantly elevated.
Yes.
Can I
Okay.
just
And
make one
Yes, please.
something which
Yes.
we had not recently, it's almost now about a year back. A patient came to us, diabetic, hypertensive. We were doing an angiography, and whenever I do an angiography, I look at the arm retina time. So this patient had an arm retina time extended to about 1 minute and 30 seconds. So I told him that there is some problem. He was classical diabetic changes, hypertensive changes. I said you should get a carotid angiography done. There is something going on, and you should get it done. And so he did not so much bother about it. And 3 weeks later, he developed a stroke.
Oh,
So then he came back, and he had taken a report, and he recovered and all that. He said, "Sir, though I developed a stroke, but I had consulted a neurosurgeon. I had gone to them. They were planning to, work on me, and he was started on Ecospin and all that. He said, because of you, I got saved and I've recovered. So
absolutely.
these
Great.
are
Yeah.
small things
Yes.
which are extremely important.
Yes.
Like what Dhananjay showed, long time back, we had a case which was being treated as a branch vein occlusion. Turned out to be as a case of CML. So what is important is that you must do a good metabolic workup of all your patients. Get a hemogram done because there may be a severe anemia which may be compounding the diabetic
Right.
retinopathy, but might turn out to be a case of what Dhananjay showed, may be a case of a CML. So I think we need to do the entire spectrum of investigations and before we say it is only diabetic. That's a small suggestion.
Yes. Great.
Dr. Shukla, one thing. So, in your last case, that is MACTEL 2, you thought there is foveal thinning is there and
Yes.
other changes are there. So, just I want to know, actually, that is the that should be in the there should be some changes in the middle layer or outer layer, but here it is whole. There is atrophic changes in particular OCT it is showing.
Yes. Yes.
So and other changes are there. So whether it is the surrounding changes that are agility, other things are there, it is due to the CLV or something else.
Oh, okay, okay. Now, yeah, so I did not show you the fellow eye actually. So, fellow eye was also showing the classic temporal leak. So, this leak that you're seeing, this late wispy leak, see, this is not a leak from the telangiectasia or the microaneurysms. See, the microaneurysm was supratemporal. If you saw that PowerPoint, the leak was just temporal to the fovea. So, temporal to the fovea leak, bilateral is very classic and it is very wispy. So wispy means it is like like a soft cotton. Actually, it's not the leakage that you see in a diabetic macular edema. So it's a very faint, very late leak, and so it's the angiography I'm talking about. Yeah,
Yes.
you are absolutely right about OCT. This was an advanced case of MACTEL actually. That's why the vision was also down. Typically in MACTEL, the changes start from the outer retina, and what you see the foveal cyst or subretinal fluid or disruption of the ellipsoid zone. But in this case, it had advanced to the level of foveal atrophy. So that's why I've seen actually. I reported the largest series of MACTEL actually from India, world's largest series, a long time back actually. So I've seen because I've seen a lot of cases. I could quickly diagnose. But this MACTEL is something which is common in diabetics and mistreated. So that's why I wanted to highlight. Not you're right.
One thing.
It's not typical, yeah.
Just 2 3 days before, we just saw one case that is there is a lot of pigmentation in one eye.
Yes.
And fovea is atrophic, and another is having the changes like these things. The patient is not diabetic or in hypertensive, so we thought it could be MACTEL, but we could not rule it out because our fundus camera is not working.
OCT?
So yeah, OCT is there, but there is some cystoid changes just in the outer retina in other eye. But this eye is totally atrophic with pigmentation. So uh, we thought it to be a case of MACTEL actually. We could not rule it out.
You can share the fundus photo and OCT actually, and
Okay.
MACTEL is actually kind of easy to diagnose, and it should be diagnosed because at least you saw that there's foveal atrophy, at least you saw that there's no macular edema. So one thing is sure, that you should not do laser treatment to this.
Yeah.
That's
It
what
is
I'm saying.
foveal atrophy and with pigmentation.
Correct.
Lot of pigments are there in one eye, but other eye is like that.
Yeah.
So because corroborating both the eyes, we thought it to be a MACTEL. But okay,
And I
thank
think-
you. Thank you
and
for
I
nice
think
presentation.
Thank you.
time, I think,
I
ma'am.
think when Dr. Shukla is speaking, there'll be a lot of questions, but I think we should go on to the next speaker. So, Saswat, should we move on?
Yes, ma'am. Sure, we should.
Yeah.
Can I
So
make a small comment?
Yeah, please.
Yeah,
Yeah,
please.
very nice cases, sir. I think you highlighted the basic, features that whenever you have something which is going out of the vogue, either it is abnormal disc, abnormal vessel in terms of dilation or tortuosity, abnormal distribution or type of hemorrhages, and just presence of one feature. You have lot of hard exudates, but no hemorrhages and no microorganisms on the, and then distribution, most probably like Dr. Ajay described, long arm retina time, probably ocular ischemic syndrome. You will see dilatation but no tortuosity, and peripheral hemorrhages or peripheral microorganism, but central is clear, again indicative for OIs. So this is one subset of cases we are dealing with. On the other hand, we should not think that everything what looks like diabetic retinopathy is diabetic retinopathy. Contrary to it, so patient looks like diabetic retinopathy, but patient has no diabetes. So first step is, of course, you rule out diabetes, and subsequently I think vice versa also holds. We should be aware of that.
Correct. Yeah. Very good points. Thank you.
Thank you, sir.
Thank you, Dr. Vinod. So today we'll move on to the last presentation, which is by Dr. Sunil Kumar Kota, who is a consultant endocrinologist at Swasthya Southern Barampur, Odisha. He has multiple publications and a lot of awards to his credit. The Best Reviewer Award, the Young Researcher Award, Best Innovation Diabetic Care Award. Welcome, Dr. Sunil. And he would be speaking on systemic targets in diabetes for protecting vision.
Thank you so much, ma'am, for this very kind words. Hope I'm visible and audible to all of you.
Yes, sir.
Yeah, first of all, thanks to Sanghamitra madam and Sucheta madam and all the office bearers of Odisha State Ophthalmological Society. But lucky that I have been in touch with so many of you, because I was listening to all the doyens in ophthalmology. So I would be straight away taking you through the systemic targets. So the PSM book tells us that we should not be only treating the disease, rather than prepare and preventing, we should not be repair and repenting. So the modern paradigm is to modify the systemic environment so that the crux of the disorder, that is the endothelial dysfunction, can be halted to a great extent. I understand this is a learned audience. I need not highlight much about this, but for a completion's sake, I have just showed this slide, the mechanisms that comes into the picture as far as the pathogenesis of diabetic retinopathy is concerned. Based on this preamble, I'm going to take you through the presentation proper. First of all, we would be talking briefly about what all are the risk factors. So as you all know, hyperglycemia, hypertension, dyslipidemia, obesity is a bit dicey. Smoking is also a bit dicey because it is one such disorder where there are some initial studies which has stated that obesity and smoking probably is beneficial as far as diabetic retinopathy is concerned. I will be telling you a bit in detail. Obstructive sleep apnea, anemia, diabetic nephropathy, cardiovascular disorder, pregnancy, and whatnot. So to tell you about dysglycemia, So there are two basic important factors. First one is the duration of diabetes, which happens to be the non-modifiable factor. But then the glycemic control, which certainly is a modifiable factor, is very important because we have ample evidence to understand that early intervention offers long-term structural protection. It is stated that the 10% reduction in HbA1c leads to 42% reduction in the risk of diabetic retinopathy progression. And if you want to actually look at the evidence, you have three studies in your slide. The first one is the DCCT study, which has been done on newly diagnosed type 1 diabetes. The UKPDS was done on newly diagnosed type 2 diabetes study. Then when we take out these two bunch, the newly diagnosed type 1 and type 2, what about its impact on the people having long-standing duration of diabetes? That was the ACCORD-I study. DCCT clearly gives us a big thumbs up to the glycemic control. With intensive glycemic control, there is a 76% reduction in the diabetic retinopathy, 54% reduction in the risk of diabetic retinopathy progression. If you look at the UKPDS, which was done in newly detected type 2 diabetes, with 1% HbA1c drop, you can see overall there was a 35% reduction in the microvascular complication, and to be specific about retinopathy, it was 31%. And ACCORD-I study, let me reiterate, it was done in a population where the diabetes duration was bit more. So even after initial years of bad glycemic control, whenever you chip in with a good glycemic control, it says that there is a 33% reduction in the progression of diabetic retinopathy. Not only that, you all must be aware of the two studies, the follow-up study of DCCT, which is known as EDIC, and the UKPDS follow-up study. What they've done is, initial years, the study population was subjected to intensive glycemic control. After some years, they were left to treat on their own. And 10 years down the line, what they saw was both the intensive arm and the conventional arm had similar HbA1c, but the ones who were treated aggressively initially, in newly diagnosed cases, they go on to show lesser degree of retinopathy. So initial years of good glycemic control is very important. What exactly is a good glycemic control? We all are aware of HbA1c. Broadly, it should be less than 7%, but there are two catch points here. If you come across a young patient who has long life expectancy, who has no risk of hypoglycemia, who has no comorbidity, you can go bit tighter, getting his HbA1c below 6.5. But on the contrary, if you look at people who are elderly, having less survival and having higher chances of hypoglycemia and higher cardiorenal impairment, you can go a bit slow. The HbA1c up to 8 is also fine. This is something which is interesting or worrisome, I must say. Early worsening of diabetic retinopathy, sometimes it is transient. So how fast should we go in our reduction of glucose? So there are no exactly concluding remarks, but then there are studies which tell us that if you reduce HbA1c by more than 2% in initial 3 to 6 months, that is called a very rapid reduction, and that sometimes can increase the chances of retinopathy. The glucose fasting should be between 80 to 130. The post meal should be less than 180. Bedtime should be between 100 to 140. Nowadays, about last 4 to 5 years, we have been talking a lot about the TIR, the time in range. It is defined as the percentage of the day's time when the sugar remains under control. It should be between 70 to 180 for more than 70% time of the day. I would be taking a bit of time here to talk about two molecules. See, metformin is safe, we know. Insulin is safe, we know, but we should not be going very aggressive. And also we know that it comes with its own challenges of frequent monitoring. Now, you would be seeing a lot of prescription from the diabetologist, physician, endocrinologist, these two molecules, the SGLT2 inhibitor and the GLP-1 receptor analogs, the gliflozins and the glutides. The gliflozins excrete the extra glucose in the urine. They reduce the blood pressure and body weight. They have cardiorenal protection, but they reduce the sugar on a gradual basis. But when it comes to GLP-1 receptor agonist, they are very robust molecules. They reduce HbA1c to the tune of 1.5 to 2%. They give rise to significant weight loss, and you can see in the slide the number of mechanisms put forward towards its neuroprotective benefits. But there is this talk about NaION. I did not define it to the August audience. We have a large number of observational studies early on which have highlighted the higher occurrence of NaION following the usage of semaglutide, which has gone off patent, you all must be aware of by this point of time. But the January 2026 published in Diabetes Care, which is the highest journal in American Diabetes Association, it was a meta-analysis of 15 longitudinal studies where it is stated that the absolute risk is 0.09%. But if you look at all the RCTs put together, this is only longitudinal study. RCTs, none of the RCTs have shown significant increase in occurrence of this particular entity. In whom does this appear? There again there is a divergence. There is a recent study published in February 2026 which says for the younger population, male gender, one who smokes continuously, and in the first 6 months, those with more than 1% HbA1c reduction, they are more prone to develop NaION. But then the previous studies used to tell us lower cup disc ratio and the one who is subjected to 2 years of cumulative exposure is the one who is more prone to develop NaION. Diabetic nephropathy is important. The microalbuminuria. The good number of times we end up doing only the urea creatinine, which only tells you about the glomerular function. We should also be doing the microalbumin, which tells us about the tubular function. Microalbuminuria indicates 2 to 4-fold increase in chances of retinopathy, and the degree of proteinuria correlates with the severity of the retinopathy, as evident from this particular slide. With increase in microalbuminuria, we find all the grades of retinopathy. But once there is a macroalbuminuria, which is defined as more than 300 milligram albumin excreted per day, it is associated with severe NPDR or PDR. And the agent to go for is the ACE inhibitor and the ARBs because of their pleiotropic benefits like reducing inflammation and oxidative stress. And we have some studies as well. The Euclid trial using lisinopril in type 1 diabetes and the RAS trial using enalapril and losartan in type 1 diabetes. You can see there is a significant reduction in progression of diabetic retinopathy when you use these kind of molecules. What about hypertension? This is again just for completion sake, I have shown this slide. I did not highlight much about this. There is a number of impact of hypertension on the ocular health, and it is the systolic blood pressure which has been significantly and independently associated with presence of diabetic retinopathy in type 2 diabetes. The UKPDS, they had in the BP arm trial, they had 2 groups, one who has 180 by 105, one who has 150 by 85. By reducing from higher to lower value, you can see there is a reduction in the risk of microaneurysm, hard exudates, and cotton wool spots. And then there was a Lale study which again showed us that for every 20 millimeter increase in blood pressure, the odds ratio for retinopathy is 1.26. So the UKPDS in newly diagnosed type 2 diabetes, it says us that tighter BP control leads to reduction of vision loss, reduction of the need of laser photocoagulation, and reduction in progression of DR. But here the catch was the tight control was defined as 150 by 85. It was done way back. What are the recent targets? You can see most of these studies tell us that if the BP is beyond 130 by 80, please start rating it. JNC 8 is bit lax with its recommendation of 140 by 90. In high-risk diabetic retinopathy, the ACCORD-I says that it can be below 120 by 80. And the first line of therapy is ACE inhibitor or ARB. If the BP is not under control, the calcium channel blockers can come in handy, and beta blockers only if you have additional cardiovascular conditions. What about dyslipidemia? Again, this slide is to tell you the mechanism behind dyslipidemia-induced aggravation of diabetic retinopathy, but there are a number of studies. This is one of the recent study. I just wanted to show it to all of you. Higher baseline total cholesterol, triglyceride, and LDL cholesterol levels were found in patients with onset of diabetic retinopathy. This again is one more study where LDL cholesterol, total cholesterol by HDL ratio, non-HDL by HDL, they all are positively related to the development of diabetic retinopathy. Targets, the slide which is being shown to you is recommended by the American College of Cardiology and American Heart Association 2026. They say for most of the patients, LDL should be less than 100. Non-HDL is always 30 plus the LDL. But if you have additional cardiovascular risk, the LDL should be less than 70 and non-HDL should be less than 100. But this is our very own guideline, 2024 Lipid Association of India. As we all know, we are metabolically more prone to develop all these complications. Here, the risk stratification is a bit different. Any diabetes patient who comes to you with age more than 40, LDL target should be less than 70. If there is more than equal to 2 risk factors or target organ damage, target should be less than 50. But one who has established atherosclerotic cardiovascular disease, LDL cholesterol should be less than 30 milligram per deciliter. We have been using statins. We all are aware of it. But nowadays, there are newer options like PCSK9 inhibitor, which is the evolocumab, which is given as once in 2 weeks to 4 weeks injection, reduces LDL cholesterol like phenomenal. There is ezetimibe. There is bempedoic acid, wherein if you are not able to get the LDL cholesterol to control despite usage of maximal doses of statin, you have these options. So the statins are the ones, preferably one who has developed complication, high intensity statin therapy is required. In the bottom two lines, you can see ezetimibe, bempedoic acid, and the once in 2 weeks subcutaneous injection of evolocumab or PCSK9 inhibitor is also there. Fenofibrate, we all know it is a triglyceride reducing medicine. This is the field study which says that the fenofibrate treatment was associated with a 31% reduction in the need for laser therapy. And it is the greatest benefit was seen in patients who already had retinopathy at baseline. This is the Accord Eye study, where again the fenofibrate was used. It reduces the progression. It also reduces the progression rate, and it was useful in the patients who already had mild to moderate retinopathy vis-a-vis patients who didn't have any retinopathy in the baseline. This is a very recent one in 2025. So not only it reduces the requirement of photocoagulation or vitrectomy, it also gives rise to less progression to proliferative diabetic retinopathy or macular edema. And this is the mechanism being put forth. A number of the ones for theoretical sake, I have just put it. Other factors, anemia, we all know, you all have been highlighting it quite efficiently and quite quite in a very significant manner. With anemia, the chances of diabetic retinopathy increases, and the gradation with anemia has also been studied. Higher is the anemia, the chances of the retinopathy getting more severe, there are ample evidence. Cardiovascular disease, it is stated that diabetic retinopathy is linked to greater plaque vulnerability. So if you have advanced diabetic retinopathy, there is chance that higher cardiovascular events would be there. And not only that, once there is an improvement in insulin sensitivity, the coronary artery calcium comes down, the diabetic retinopathy, the PDR risk all come down. So if you have diabetic retinopathy, so probably aggressive CV risk optimization is the one which should be looking at. So STENO2 is a study which has tried to tell us that in type 2 diabetes, you are not only supposed to look at diabetes, you need to look at the blood pressure, you need to look at the cholesterol, you need to look at the antiplatelet therapy for the patient to get overall better reduction in all the vascular complications. Pregnancy, yes, the mechanisms I would not be talking about, but then there is a development of new DR and progression of existing diabetic retinopathy. So therefore, one who is actually type 1 or type 2 diabetic person planning for pregnancy, at the outset, you do the ophthalmoscopic evaluation and the follow-up pattern you all are aware of. Severe NPDR or worse every 1 to 3 months, no diabetic retinopathy once in every 3 to 12 months. It doesn't apply to GDM. Smoking. So as I was telling you, type 1 diabetes, unequivocally, smoking is associated with increase in risk of retinopathy. Type 2 diabetes, some meta-analysis told us that in type 2 diabetes patients who are smoking, there is a lower risk of retinopathy, but then the recent studies are also telling us that the smoking is associated with more severe form of NPDR, PDR, like vitreous hemorrhage. What about obesity? Abdominal obesity is consistently linked to high risk of diabetic retinopathy, whereas the generalized obesity, there is a term which you all might have come across. This is something called obesity paradox, where obesity is protective against some of the complications, out of which the retinopathy is one such, which is stated that it is because of better nutritional status, or probably the sugar has come down and the weight has gone up. It is a metabolically healthy kind of obesity. So there are 3 studies I have highlighted. Some studies tell us that the waist-hip ratio is dangerous. If waist is higher, waist-hip ratio is higher, that is dangerous. And some studies have told us that waist height ratio which is also known as the index of central obesity, that also can be associated with high risk of diabetic retinopathy. But obstructive sleep apnea, where there is snoring, daytime somnolence, is unequivocally associated with increase in chances of severe NPDR and other systemic complications like stroke, MI, and death. So to conclude, this is one interesting slide where I was also a bit amused to find this. If the person is specifically having macular edema with hard exudates, here the dyslipidemia comes into the picture. You treat the LDL cholesterol, you treat the triglyceride. But other forms of diabetic retinopathy, they preferably look at the wholesome approach where you need to control the blood pressure, the sugar, and also the cholesterol, apart from taking care of the smoking, anemia, and others. So take home message, it is not only limited to eyes, it also indicates that there is a systemic vascular disease manifestation. So glucose control is important, but we need to be careful, especially for the ones who have very high HbA1c or baseline retinopathy. We need to go a bit slow. Blood pressure, lipids are important. And retinal state, for the retinal state, you all were talking vividly about the pioglitazone, the GLP-1 receptor analogs. We have to be a bit careful while we treat that, and we need to screen regularly, and we also need to refer to our ophtha friends for the patients to derive maximum benefit. Jai Siya Ram, and wishing you all a happy Ram Navami.
Thank you, Dr. Sunil. It was a very precise, very complete presentation. So many take-home messages for all of us. And of course, many questions answered. And what amused me much was the obesity paradox.
Yeah.
I never knew about that. Yeah, Dr.
Any questions I would like to answer? Or maybe I will get some insights from the
So I have a question, and anybody can answer. Why does diabetes worsen with the better control? What is the pathomechanism? Anybody
Diabetes.
can answer. I don't know. Why should when you when you give insulin to these patients and the diabetes, the sugar gets controlled better, but the diabetic retinopathy worsens?
So the proposed mechanism is that the control, which is at a more, am I audible?
Yeah.
Yeah, you're audible.
It is stated that the vascular endothelial stability is dented to a great extent when the blood sugar control is very rapid. That is one hypothesis which is being put forward even for the insulin-induced rapid glycemic control and also for this GLP-1 receptor analog-induced rapid glycemic control. But again, these are hypotheses.
Yeah, I have something to add to this actually. So Ajay, this worsening of diabetic retinopathy was reported by DCCT actually. That study was done in 1970s or something.
Yeah.
And
Yes.
they brought down the HbA1c very rapidly from a very uncontrolled levels. Now, I'll tell you. So it was like 10.5 HbA1c and they brought it down to 7 or something. So this is the kind of rapidity of drop actually. So that's one thing. And second thing, what was exactly the worsening? So the worsening as reported in DCCT was appearance of cotton wool spots in mild NPDR. So they did not take PDR patient for information. They took mild to moderate NPDR. They did not have severe NPDR. So worsening for them meant appearance of cotton wool spots in previously mild NPDR, which reversed. So actually, this is what the worsening we don't even care about actually, right? So and now we know that there are other markers like inflammation or other markers which may go off, but basically worsening was not great. So you don't have to worry. And we do not have that kind of poor controls nowadays, so that we have to worry that much about worsening. So worsening we do not worry about. That's what I'm saying. In short,
And we don't bring it down so rapidly anyway.
it's not in that levels anymore. Actually, we don't see 10.5 HbA1cs like we used to see other. As he also Sunil beautifully pointed out that earlier, if you look at DCCT, what was tight control? It was 150 by 85. Now the tight control is 120 by 80. The current guidelines, ADA guidelines say that if you have a BP of 120 by 80, don't be cocky. Start doing salt restriction because you are at the upper limit of normal. You are not healthy. So even an 70-year-old should have a BP of less than 120/80. That's what ADA guidelines say. So which WHO doesn't conquer, but I personally believe that makes some sense actually. So a great talk, Sunil. Thank you.
Actually, the previous what you were also alluding to, the previous deterioration, all of them were transient. But nowadays, with the
Yes.
GLP-1 analog, it is difficult on our part also because, yes, if you're having a patient of diabetes, we can tell them that, yes, you had retinopathy and it regressed. But then when we are using it for a patient with obesity, it becomes very tricky why he suddenly deteriorated.
Yeah, I'm just putting a perspective. And another thing, they were all type 1 diabetics. DCC dealt with only type 1 diabetics.
Type 1.
So again, these are patients who progress rapidly anyway.
True.
Thank you, Dr. Sunil. That was a wonderful talk. And I
Thank
think
you,
even
sir.
if someone did not tell me, I would can make out that is talk is made by a person who is very thorough with, all the studies. So excellent talk. I think
Thank you,
we
sir.
really enjoyed. I had two, three questions. So one, you talked about SGLT2 inhibitors and GLP-1 receptor agonists. So I'm kind of into it. And what is your opinion about the diabetic epidemic we are in, and what is going to happen to it with the advent of these drugs?
See, actually, sir, I would like to quote one recent study, which was the ICMR INDIAB study, which is trying to look at the prevalence of diabetes and all other comorbidities across India. Despite having so much of knowledge sharing and the advent of the new incoming molecules, the glycemic control is abysmally low. Only 17 to 20% people are having good glycemic control. And 80 to 83% people are still having bad glycemic control. The one of the major reasons cited here is because it is a disorder which is not associated with symptoms. Probably people tend to take it lightly. And one thing is with the entry of this innovator or the sorry generic semaglutide, if it clicks well, probably we can tackle the menace of obesity, and the uh, trend of diabetes can be halted to some extent. But again, there are a lot of concern. You would be seeing a lot of those scientific materials where semaglutide is a highly specialized molecule, a protein. So it's difficult to replicate the exact innovator molecule. As the days unfold, we would be coming to know how it changes the scenario. But yes, we should be hopeful. But as of now, the picture is not that great as far as glycemic control is concerned.
Yeah, I heard like Monjaro, it was the highest grossing molecule,
Yes,
toppling over Augmentin in a very
everything.
short span of time. So, how and where do we use these SGLT2 inhibitors versus, GLP-1 agonist?
GLP-1.
Like which one are preferred in which scenarios?
So the guidelines have clear cut. If you have a established atherosclerotic cardiovascular disease, both gliflozins and these GLP-1 receptor analogs are equally placed as far as the cardiorenal protection is concerned. If there is heart failure or chronic kidney disease, SGLT2 inhibitors scores over the GLP-1 receptor analog. But the GLP-1 receptor analog, the major advantage is weight loss. So what we have seen is, sir, I have also seen like the patient, somebody is on 50 to 60 units of insulin a day. He takes this, any of these GLP-1 receptor analog. In 3 months span, he reduces weight by 9 to 10 kgs. The insulin requirement drops down by significant, a whopping, I must say, 30 units, 40 units, they come down like this. So weight, obesity, very high insulin requirement. If you have NASH, non-alcoholic steatohepatitis, the semaglutide is absolutely approved. If you have obstructive sleep apnea, tirzepatide is the first molecule approved globally for treatment of obstructive sleep apnea also. So they have different, I can say, indications. SGLT2 inhibitor has got cheaper, so the usage has gone up. But with this footfall of the generic semaglutide, probably this would also go. But then it is a tricky one because copying protein is not like getting a biosimilar. So in the days to come, we would be understanding how these generics would be helping us.
Wonderful. Thank you. Thank you so much.
Thank you,
Yeah.
sir.
I had a small question, Dr. Sunil. What
Ah,
about
sir.
the ApoB markers? ApoB, you did not talk about that because that is, people say that get your ApoB done instead of the lipid profile.
So
I
actually,
think we are more of patients now rather than doctors.
sir, actually,
Vinod,
it is-
I did not know this.
No,
No, I'm not. I mean to
neither
say
Vinod nor I am a
we are
patient, but yes.
we are speaking more like patients than
Yeah,
doctors.
yeah,
Okay.
exactly. Yeah.
no. Actually, it is absolutely an important very. In fact, in our MBBS group also, this is a common discussion nowadays because we see a lot of young onset CADs. See, sir,
Yes.
actually, if you look at the recent Lipid Association of India, that is the 2024, and the 2026 American College of Cardiology Guidelines on Dyslipidemia, which was published few days back only, still the major marker is LDL, LDL, LDL.
Okay.
Second comes in Indian setting because of the metabolic syndrome, the triglyceride remains high. You just need to deduct the HDL from the total cholesterol and you get the non-HDL cholesterol. Because in our case, triglyceride remains high and the non-HDL should be 30 plus your LDL. If you want to further go deep down, there are two more risk factors, ApoB, then comes the lipoprotein A. But frankly speaking, I have never asked anyone to go for this test, but people do end up coming with those reports on their own. Sir, ye badha hua hai, kya kare? But again, point is, reduction of ApoB is also with the same kind of drugs which we have discussed just now.
Okay.
And
That's a
reduction
great
of
point.
ApoB and reduction of lipoprotein A has not been significantly studied to be associated with reduction of CV risk, like the LDL cholesterol.
Okay, great. Great
So
point.
LDL is the best, but if you want further insights, yes, ApoB, lipoprotein A would be
Yeah, so
additionally
we need
handy.
not bother. It's just a curiosity. Thank you. Super.
Sir,
Dr. Sunil, what level of LDL
Thank you,
you
Dr.
target
Sunil.
in your practice?
sir, we go by LAI. Any patient more than 40 years of age, no risk factors, LDL should be less than 70.
Wow.
If he has a event of like atherosclerotic cardiovascular disease or any other target organ damage, less than 50. That is the target, sir.
Oh, wow.
I personally feel. Sorry, please go
Thank
ahead.
you, sir.
Practically a bit difficult, but that's how
We
the
have
guidelines stand and
no,
we
no,
have been
sir,
instructed to follow.
I personally feel 5 years down the
I
line,
think this,
we'll be sitting and talking how the diabetic epidemic was a thing of the past.
Amen.
So hopefully,
let's hope for the best, sir.
yes.
I think, or hopefully. I think the last talk by Dr. Sunil was the most illuminating. Most of us were all stuck to the screen of him saying, okay, these are the things coming up. May I request Dr. Sangamitra ma'am finish?
Yeah. I think Dr. Sucheta is going to give the vote of thanks, and probably we are shooting out. It's
Yes, yes.
9:40, but everybody is probably stuck up
Yeah, it's 9:40
because of
already.
Dr. Sunil's talk. Yeah. Thank you, Dr.
Sorry
Sunil.
for making you late, making it late.
No. We were so hooked up to your talk.
Thank you, man. Thank you.
Yeah. Thank you so much.
Yeah.
So thank you all for this wonderful webinar. We had great talks from both Dr. Brutendu with a case discussion, with Dr. Sukla showing what is not diabetic retinopathy, and Dr. Sunil with all the newer drugs which is coming up and how diabetes will be controlled, where you won't be getting diabetic retinopathy. So then I don't know what the diabetic retina specialist will be doing. So it's still a myth that you will not have diabetic retinopathy as far as we know. So years are there to go ahead and you will be getting more of this recalcitrant diabetic retinopathy. And now diabetic retinopathy is becoming more like a general ophthalmologist, those who are working on it. But we should have enough knowledge to handle these patients than just taking them. So I actually invite Dr. Santosh Mahapatra, who is the General Secretary, to give the vote of thanks for this session. Dr. Santosh, over to you.
Before he speaks out, Bhai happens to be my senior. It's really nice to see him after.
Thank you, Sunil, remembering me. So it was really mesmerizing listening to everything, the talks, the discussion. So I was just keeping quiet and listening to everything.
Santosh, you are muted.
Dr. Santosh, you're muted.
Santosh,
Oh.
you're muted.
Oh, sorry. I spoke so much, but I so sorry. But, thank you, Sunil, for remembering me, and it was a great that you have evolved so much, and you are thorough in your subject. And I'm very lucky that our new scientific committee under leadership of Dr. Sucheta is doing such a nice job, and we all are glued to all the talks and discussions. It was so heartening to see that we are having so good seminars. I would like to thank each and everyone, all the chairpersons and the panelists who have contributed so much, and particularly the speakers, Dr. Brutendu, Dhananjay sir, and Sunil. You are the showstopper, and the panelists have given good inputs. I think we should also include questions from the audience next time. It's a just suggestion to Sucheta madam. And I would also like to thank Intode for providing us the platform.
So before we end up, I just also want to thank the audience who will be sitting there and watching this, because without them, this webinar cannot grow. So thank you all, and a very good night. And thank especially Sangamitra and Shashwat for taking so much of pain for this webinar. Thank you all.
Thank you.